Hello. Welcome to the North Carolina Pharmacists Association webinar series. We appreciate your participation in this presentation titled Prepare Yourself, Updates in HIV Pre-Exposure Prophylaxis. Following the webinar, please be sure to follow the instructions alongside the webinar's link on the NCAP website to obtain CE. NCAP members will receive 1 hour of free NC CE credit. Our speakers today are PGY2 infectious disease residents from Novant Health, Dr. Bria Benson and Dr. Kiet Nguyen.
We have nothing to disclose for this presentation. Our objectives today will be to review the current guideline recommendations on HIV pre-exposure prophylaxis, or PrEP, discuss barriers and concerns that limit prescribing and compliance, differentiate current pharmacotherapy options, and recognize drugs in the pipeline. Human immunodeficiency virus, or HIV, is a retrovirus that causes acquired immunodeficiency syndrome, or AIDS. An estimated 1.1 million people in the U.S. have HIV. That estimate is for those over the age of 13 years old, and unfortunately, there are still an estimated 14% of the HIV population that has not been diagnosed, and they are included in that number as well. Overall, the prevalence of HIV continues to rise. The incidence of HIV has remained stable, however. In 2018, almost 38,000 patients received a new HIV diagnosis, and specifically looking at North Carolina as a state, we rank among the top 10 for new HIV diagnoses. Earlier this year in February, the CDC released a plan to end the HIV epidemic in the U.S. The overall goal is a 75% reduction in the number of new HIV infections by the year of 2025, and by at least 90% by the year of 2030. The U.S. Department of Health and Human Services will work with each community to establish local teams to implement a 4-part strategy that includes the diagnosis of all people with HIV as early as possible after infection, treating the infection rapidly and effectively to achieve sustained viral suppression, preventing new HIV transmission, and responding quickly to potential HIV outbreaks to get needed prevention and treatment services to people who need them. Taking a closer look at prevention, proposed efforts to prevent the transmission within the plan include addressing community needs like increasing PrEP use, utilizing comprehensive syringe service programs, and increasing outreach for at-risk populations. The initiative focuses specific resources on areas where HIV transmission occurs most frequently. So from 2016 to 2017, more than 50% of new HIV diagnoses occurred in only 48 counties in the U.S. Knowing this information, the CDC would like to focus initial efforts on reducing transmission in those counties and certain states if they had multiple counties that needed to be targeted. So you can see those counties and states on the map. For North Carolina, the Mecklenburg County is one of the top 48, so we can expect increased resources dedicated there to achieve this goal within the next year if everything goes according to plan. The CDC proposes 6 different prevention strategies to reduce the transmission of HIV. While the focus of today's presentation will be on HIV PrEP, we want to take a moment to briefly discuss the other 5 prevention strategies and their effectiveness. One of the most important prevention strategies for the transmission of HIV is the treatment of HIV. Long ago in HIV research, it was recognized that viral load was a key determinant of HIV transmission. With our highly active antiretroviral therapy that we have today, we have the ability to reduce a patient's viral load to undetectable levels in the blood. Findings from a large National Institute of Allergic and Infectious Diseases supported clinical trial that has tracked more than 2,000 heterosexual couples over 10 years. It demonstrated clear evidence that consistent suppression of HIV with antiretroviral therapy prevents sexual transmission of the virus. You will often hear this prevention strategy simply referred to as U equals U, or undetectable equals untransmittable. U equals U is 100% effective at preventing HIV transmission, which is really exciting and promising, but also highlights the importance of quickly diagnosing HIV and initiating HIV treatment. Other strategies to prevent the sexual transmission of HIV include condoms, which studies have demonstrated to have an efficacy of 63 to 91%, only participating in low-risk sex, which has an unknown efficacy, only having sex with partners who have the same HIV status, or seroconcordant couples, which is a 100% effective strategy, but relies on everyone knowing their status and the status of their partners. Again, highlighting the importance of testing, and the last strategy would be abstinence. The prevention strategy we will focus on is HIV PrEP, though. PrEP is the use of antiretroviral drugs by HIV-negative individuals to reduce the risk of acquiring HIV infection. Current clinical practice guidelines on HIV PrEP by the U.S. Public Health Service were last updated in 2017. They identified 3 populations in which PrEP is indicated, and those include men who have sex with men, or MSM, heterosexual men and women, and persons who inject drugs, or PWID. They also specify that these indications are only in the adult population, as there's still insufficient evidence to support the use in adolescents. Within these identified populations, not everyone is at substantial risk for HIV transmission, so you have to identify those persons first before really deciding if someone would be eligible for HIV or would need it. For the MSM population, risk factors include having an HIV-positive sexual partner, recent bacterial sexually transmitted infections, or STIs, and those STIs for that population includes gonorrhea, chlamydia, and syphilis, having a high number of sex partners, having a history of inconsistent or no condom use, and commercial sex work. For the heterosexual population, you will see a lot of the same risk factors, but important differences are that the bacterial STIs that you're concerned for are gonorrhea and syphilis, and an additional risk factor is simply living in a high HIV prevalence area or network. Additional risk factors for persons who inject drugs, or PWID, is first recognizing that there will be overlap with the other risk factors depending on if they are sexually active, and additional risk factors are having HIV-positive injecting partners and sharing equipment. Before we get into the updates on HIV PrEP, we think it's important to know the landmark trials that led to the clinical practice guideline recommendations that we have today. So over the next couple of slides, we'll review these major trials in detail. The major trials that led to PrEP being indicated in the MSM population are the IPREX and US MSM studies, published in 2013 and 2010 respectively. The IPrEX study was a phase 3 randomized controlled trial that evaluated PrEP in the MSM population and transgender women who had sex with men. They looked at tenofovir disoproxil fumarate, or TDF, in combination with emtricitabine versus placebo. They found an incidence of HIV transmission to be about 3% amongst those on PrEP, compared to about 5% on placebo, which was a 44% risk reduction. A major limitation of this study was adherence. So they assessed adherence using 3 different methods: self-report, pill counts, and blood detection, or blood concentrations of tenofovir. specifically looking at the efficacy in patients who had detectable blood concentrations, they found that the reduction was 92% in that group compared to others. The U.S. MSM study was a phase 2 randomized control trial that looked at the MSM population solely. For the study, patients received tenofovir monotherapy or placebo. The tenofovir treatment group was divided into 2 different arms. So one arm delayed treatment 9 months and the other started immediately. The incidence of HIV transmission was about 1.5% in the PrEP group compared to 2% in the placebo group. And while percentage-wise there was not a major difference, all 3 of the HIV infections were in the tenofovir group, where patients were in the delayed arm and had not yet received tenofovir. So essentially, the infection rate amongst those actually on PrEP was 0%. And this was likely due to a high adherence rate of greater than 92% by pill count. 2 of the major trials that led to PrEP being indicated in heterosexual men and women were the Partners PrEP and TDF2 trials. Both were published in 2012. Partners PrEP was a phase 3 randomized controlled trial that included serodiscordant couples. Serodiscordant couples are couples that with a mixed HIV status, so one partner has HIV and the other does not. Patients were divided into 3 different arms, tenofovir monotherapy, tenofovir in combination with emtricitabine, or placebo. The incidence of HIV transmission was 1% in the tenofovir group, 0.8% in the tenofovir emtricitabine group, and about 3% in the placebo group, which was a 67% and 75% reduction in risk of HIV transmission, respectively. A subgroup of those with detectable tenofovir levels showed a 90% risk reduction, so showing similar to the last trial, showing that adherence is correlated with efficacy. The TDF2 trial was a phase 2 randomized controlled trial that looked at heterosexual men and women, and patients were assigned to receive tenofovir emtricitabine or placebo, and they found a 62% risk reduction in HIV transmission, and this study was unfortunately limited by a high loss to follow-up. The last landmark trial that I want to review is called the Bangkok tenofovir study, which was published in 2013. It was a phase 3 randomized controlled trial that randomized persons who inject drugs to tenofovir monotherapy or placebo. HIV transmission was reduced by 49%, and there were minimal limitations. Unfortunately, this is pretty much the only large trial that evaluated this population. So overall, the data is still limited in persons who inject drugs. It is based on those landmark trials that we have our current guideline recommendations for HIV PrEP, which is tenofovir in combination with emtricitabine, also known by the brand name Truvada, taken daily in our indicated populations at substantial risk, including serodiscordant couples. And so they decided on tenofovir emtricitabine over tenofovir monotherapy, because although a lot of the studies looked at tenofovir monotherapy, the few that did look at tenofovir monotherapy compared to combination found that there was improved efficacy with the combination of tenofovir with emtricitabine over tenofovir by itself. So despite our PrEP guidelines first being published in 2014 and having a lot of those landmark trials come out in 2013 or earlier, we've still seen kind of a slow uptake in the utilization of PrEP to prevent HIV transmission. And that's due to several different barriers that we have identified over the course of the last 5 or so years, And so we want to take the time to address some of those here. The first barrier we want to discuss is actually identifying substantial risk. So routinely taking a sexual history is a necessary first step in identifying these patients. And while doing this is recommended as part of ongoing primary care, the sexual history is often deferred for one of the following reasons, including urgent care issues, provider discomfort, and anticipated patient discomfort. A significant portion of the U.S. population does not seek medical care unless there is an urgent issue in which that urgent issue is being addressed at the visit and routine history is kind of being skipped. Actually obtaining a sexual history when it is done properly also requires a physician to ask questions such as whether they have had sex with men, women, or both, how many times, whether it was anal or vaginal, and how many times did they have sex without a condom. As you can imagine, these questions can be extremely awkward for the provider, and they often anticipate patient discomfort as well. And so due to that fear of losing or not building trust with the patient, they'll defer. Recommendations to overcome this barrier include encouraging routine primary care visits, debunking any misconceptions about who can get HIV. So oftentimes, obtaining a sexual history is limited to select patients that providers feel are at risk without really having to ask them or bring up the conversation themselves, such as those that are young or unmarried and seeking contraception. So by debunking this notion that only those persons can get HIV or are at risk will improve the routine history of actually obtaining a sexual history. And lastly, providing provider guidance on how to take a sexual history with less provider and patient discomfort. So strategies to do this are to introduce the topic as routine practice with every patient and just making sure the patient is aware that it's necessary for appropriate care. And then always closing the conversation by reaffirming patient confidentiality so the patient knows that nothing discussed will go outside of the room. Another barrier is the provider fear that by prescribing PrEP, they are encouraging high-risk sex. A study looking at this concern was published in JAMA in 2019. It was a retrospective observational cohort study of the pre-exposure prophylaxis expanded study, or PrEPX. They basically took the MSM cohort on daily Truvada for PrEP and retrospectively compared their pre- and post-enrollment STI incidence. Of note, the patients in the study received quarterly STI testing, so they had a lot of data, and over 2,000 patients were included. They were specifically looking at the incidence of chlamydia, gonorrhea, or syphilis, and they found that pre-enrollment, the incidence of STIs was about 70 per 100 person years compared to 92 post-enrollment. That incidence rate ratio was 1.41 for any STI and 1.17 for chlamydia, which was also statistically significant. And they concluded that among the MSM population, that there was an increased incidence of bacterial STIs following the initiation of PrEP. And so knowing this information, we have a couple of recommendations of how to overcome this barrier. I think the first one is understanding that the provider fear or concern is valid, and we have data to prove that we do have an increased incidence of STIs. A way to combat that barrier is to aggressively counsel patients on the importance of continued safe sex and frequent STI monitoring after PrEP initiation. So when we talk about how to start PrEP and how to monitor PrEP, we'll go into the specific recommendations for STI monitoring based on population, but we also would encourage providers to test more frequently if there is a patient-specific concern or if this is a major barrier for them prescribing PrEP. Another barrier is the concern for increased antiretroviral resistance. To take a closer look at this concern, they went back and looked at all the landmark trials previously discussed, and they looked at the patients who acquired HIV infection and whether they had any sort of antiretroviral resistance after transmission. Overall, looking at the table, you would notice that there were low rates of antiretroviral resistance for the IPrEP study, US MSM, Partners PrEP, TDF2, and Bangkok tenofovir studies. There were 0 resistant viruses amongst patients who were infected after baseline. So basically, the patients that got HIV were infected at baseline before starting tenofovir, and some of those patients did have resistant viruses. The last study in the table, the FEM-PrEP study, was one of the only studies that has found resistant viruses in patients infected after baseline, which is important to highlight, but they identified only 4 of 33 patients who had resistant viruses. So the big thing I want everyone to take away from, all these studies and this information is that it highlights what we already know about HIV treatment, and that is that tenofovir and emtricitabine is an inadequate therapy for an established infection and can quickly lead to resistance. It highlights the importance of excluding acute infection before starting anyone on PrEP, and it highlights the need for frequent HIV testing after the initiation of PrEP to quickly identify patients who have an acute infection and get them on an appropriate antiretroviral regimen early. And the last barrier that we want to discuss is one of the not being able to afford PrEP and limited access to PrEP. So there are some patient assistance programs available. So for uninsured patients, Gilead's Advancing Access Patient Assistance Program completely covers the cost of Truvada or Descovy if the patient is at a certain level below the poverty line. This program additionally applies for patients who have had either medication denied through their insurance. Uninsured patients may additionally be eligible through the federal Ready, Set, PrEP program, which is part of the Ending HIV Epidemic program mentioned at the beginning of the presentation. There is no income limit for the federal Ready, Set, PrEP program. Another option for insured patients is copay coupon programs under the Advancing Access program. It provides up to $7,200 a year for prescription copays. And these represent just a few of the well-known programs, but there are various other resources as well. So another way to overcome the barrier of decreased access to providers that prescribe PrEP or HIV clinics or additional community resources is PrEPlocator.org, which is a national directory of providers who prescribe PrEP in the U.S. It can be utilized to identify those who would provide services to uninsured patients and for patients to find appropriate patient assistance programs to meet their needs as well. The picture to the right of the slide is the results for PrEPlocator in the Charlotte-Mecklenburg area. So patients can find a provider close to them, and that's what it will look like when you're looking in your area. Additionally, there are AIDS service organizations and community-based organizations that can be another useful tool in connecting patients and locating additional services, such as STI or HIV testing, mental health and substance abuse counseling, and Ryan White clinics, such as locator.aids.gov. Now that we have addressed some of the major barriers, we will discuss how to start someone on PrEP and updates and treatment recommendations and considerations.
Thank you, Dr. Benson. So now let's discuss baseline monitoring necessary for starting PrEP. One of the most important considerations is confirming patients do not have HIV when they start PrEP. If PrEP is inadvertently started in an HIV-positive individual, resistance may quickly develop to the agents utilized. In addition to baseline testing, it is recommended that patients are tested every 3 months to ensure that they did not acquire HIV. This 3-month testing period is often tied to refilling or reissuing prescriptions for PrEP. Guidelines do mention that this can be done through laboratory draws or through point-of-care finger tests, but to avoid rapid oral tests due to reduced sensitivity. Renal function should be assessed when starting PrEP and reassessed at least every 6 months, and potentially more often if there are additional threats to renal safety, such as multiple concomitant nephrotoxins. PrEP is no longer recommended in those who have a creatinine clearance of less than 60 if Truvada is being utilized, or tenofovir disoproxil fumarate and emtricitabine, or 30 mL per minute if Descovy or tenofovir alafenamide emtricitabine is being utilized. For the rest of the presentation, I'll be referring to tenofovir alafenamide and emtricitabine as Descovy for simplicity's sake. It's important to note that increasing serum creatinine isn't necessarily a contraindication for use unless their creatinine clearance drops below the cutoffs. Here's a flow diagram for the decision-making and starting PrEP from the guidelines. If the initial immunoassay testing is negative or indeterminate, it is important to additionally assess the patient for any signs and symptoms of acute HIV infection in the prior 4 weeks in conjunction with the test results. If they have not had any symptoms, it may be assumed that they are negative. If they do have symptoms, some additional testing is required and includes 3 different strategies. The preferred method is sending for HIV antibody antigen assays for confirmatory testing. If negative, patients are eligible to be started on PrEP, which is highlighted in the blue boxes. Other options include testing for a viral load or deferring PrEP decisions and retesting for antibodies in a month. Any scenario that leads you to a blue box in this diagram indicates that patients are HIV negative and eligible to start PrEP. Red boxes denote patients that are HIV positive and PrEP should not be started and full antiretroviral therapy should be initiated. These green boxes at the end of the algorithm indicate HIV status is unclear and PrEP decisions should be deferred. Patients should additionally be tested for hepatitis B and C if they're at increased risk. Hepatitis B is not necessarily a contraindication for PrEP use, but determining hepatitis B status is important as both agents used in PrEP are active in hepatitis B. If patients are started on PrEP and have unknown underlying hepatitis B infection, they may have a hepatitis B flare when they stop PrEP. If not previously vaccinated or immune through natural infection, patients are at substantial risk for HIV infection and should be vaccinated for hepatitis B. Patients should additionally be screened for hepatitis C, as many of the risk factors overlap with HIV infection. This may be a consideration for potential drug interactions with hepatitis C regimens, namely ledipasvir sofosbuvir. Patients should additionally be screened for other sexually transmitted infections, and all patients should receive syphilis and gonorrhea testing at baseline and semi-annual visits. Chlamydia is not as strongly associated with HIV acquisition as other sexually transmitted infections, so chlamydia testing for women is deferred to the 2015 STD guidelines, which recommend annual screening for sexually active women below the age of 25 or older women at higher risk of infection. For MSM population, however, chlamydia screening is recommended at baseline and at semi-annual visits. For bone health, baseline DEXA scans or other assessments of bone health are not necessarily required for those starting PrEP, but may be considered for those at higher risk of osteoporosis or previous history of bone fractures. This is important to note because TDF-containing regimens have been previously associated with decreased bone mineral density in patients with HIV being treated with antiretroviral therapy, towards a 3 to 4% decrease in these individuals. The same rates are not necessarily observed in those not infected with HIV and are taking PrEP. In the IPrEP study, which examined MSM and transgender women taking PrEP, there was only a 1% observed decline. However, it is worth mentioning that those receiving Truvada had statistically significant differences in bone mineral loss within the first 24 weeks, but this seemed to stabilize in the hip over time. It is clinically unclear the exact significance of this 1% difference on long-term clinical outcomes, but this study did note that there was not a statistically significant difference with regards to fractures in the study period. Because of the small treatment difference and lack of fractures, the guidelines do not recommend DEXA scans or other bone health assessments unless patients are at higher risk of osteoporosis or bone fractures. Of note, Descovy may have a theoretical benefit over Truvada in this regard. We have discussed most of the monitoring items previously, but wanted to include this slide to portray different time points in monitoring associated with these intervals. In addition to the items previously discussed, it is recommended to perform a pregnancy test every 3 months if applicable, and reissue refills for PrEP each 3 months as well. Another item that was not previously discussed is the importance of assessing side effects, patient adherence, and risky behaviors. Some goals of PrEP patient counseling include reducing individual risk of HIV acquisition by promoting condom use and providing information on other risk reduction strategies and other risky behaviors. It is additionally important to monitor patients for signs and symptoms of active HIV infections, as we would quickly like to diagnose these patients and start them on full antiretroviral therapy, and also to reduce the risk of resistance to the agents used in PrEP. Medication-relied side effects are important to note, as these may lead to decreased patient adherence and potentially untoward outcomes if patients are not taking PrEP consistently. Each visit, it will be important to elicit any use of new medications to assess drug interactions and for side effects that may lead to toxicities. The time to protection is currently unknown, so it is important to counsel patients on safe sex practices, especially when starting PrEP. At this time, it's currently unknown what concentrations are protective in respective tissue sites. It is, however, observed that max concentrations are achieved in the blood and cervicovaginal tissues at 20 days, 7 days in rectal tissue, and uncertain at this time in penile tissue. As Dr. Benson mentioned earlier, Truvada is the only PrEP option discussed within the guidelines, but throughout the presentation, we've alluded to the use of Descovy for the indication of PrEP. The PrEP guidelines were published in 2017, and Descovy was actually recently FDA approved for PrEP in 2019 through the Discover trial. Some key differences are the populations that it's approved in. Truvada is currently approved in MSM, penile vaginal sex, and intravenous drug users, while Descovy is approved only for MSM and transgender women, meaning women who are born male at birth, so not approved in cisgender women or intravenous drug users. This comes largely from some concerns that tenofovir alafenamide does not concentrate in vaginal tissues as well. In addition, these populations were left out of the Discover study. Of note, there is some data to support TDF alone for PrEP in certain populations. However, this strategy is often not utilized in the U.S., as PrEP is often fairly well tolerated and so many assistance programs exist. Some other things to note is that there is a generic on the horizon for Truvada, which may help with affordability. Some projections have this available as soon as later this year. The biggest difference between the components of Truvada and Descovy is the salt form of tenofovir included within the formulation. Both are prodrugs converted to the active form within the plasma. If we notice much more of tenofovir disoproxil is in the plasma compared to tenofovir alafenamide. Tenofovir alafenamide is able to much more effectively concentrate within the lymphoid tissues than tenofovir disoproxil, hence the lower associated dose. As there are higher concentrations in the target cell with tenofovir alafenamide instead of the plasma, this is the postulated reason for the decreased bone and renal toxicity seen with tenofovir disoproxil. However, there is a concern for tenofovir alafenamide to concentrate as well as tenofovir disoproxil in vaginal tissues. But remember, the data extrapolated from PK studies regarding concentrations may not fully inform us of the protective effect, as protective on levels are still unknown. The Discover trial compared clinical outcomes of Truvada and Descovy for the indication of PrEP in men and transgender women at risk of HIV infection. The full results of this study are currently not published, but wanted to review some of the highlights that are currently available. In this study, 99.7% of patients taking Descovy for PrEP stayed HIV negative, and the study found that Descovy was non-inferior to Truvada for this indication. When they examined the effect on renal parameters, there was a statistically significant difference in median change in baseline renal function favoring Descovy, with a difference of 4 mils per minute. It is also important to note that although this was statistically significant, it is unknown the effect of this small difference on clinical and longer-term outcomes. A similar result was seen when comparing bone health between Descovy and Truvada. A statistically significant difference in bone density between the two in both the lumbar, spine, and the hip. Much like the renal outcome, it's unclear the difference this may have on long-term clinical outcomes, but both were interesting observations and could potentially be considerations in high-risk populations. Now let's revisit some data regarding tenofovir alafenamide concentrations in vaginal tissues. As previously discussed, there may be some concerns whether tenofovir alafenamide reaches adequate concentrations in vaginal tissues. One PK study conducted by Cottrell and colleagues gave varying concentrations of tenofovir alafenamide to healthy seronegative women. When they recovered vaginal tissue concentrations, they noticed that levels were twofold lower in the female genital tract with tenofovir alafenamide than with tenofovir disoproxil. Again, unsure of the clinical benefit of this, as protective levels are unknown. A separate study by Masood and colleagues published in 2019 examined the effect of Descovy or tenofovir alafenamide alone in macaque monkeys exposed to simian immunodeficiency virus, which is similar to HIV but just infects the macaque monkey population. In this figure in the top right, this represents a cohort of macaque monkeys treated with Descovy. There was a statistically significant difference with regards to time to infection and proportion of macaque monkeys being infected. However, the same was not necessarily seen when using tenofovir alafenamide alone. There was no statistically significant difference with respect to time to infection, but there was a statistically significant difference for proportion of macaque monkeys becoming infected, suggesting partial efficacy of tenofovir alafenamide alone. Currently, the literature for Descovy is mixed in women, so it's important to emphasize that they currently are not interchangeable, Descovy and Truvada, for all indications of populations. At this time, Descovy remains not FDA approved for this population. Lastly, we want to update you on some emerging strategies and options for PrEP. An alternative strategy that has been studied is on-demand PrEP. Additionally, there has been several alternative options that are in development, including a long-acting injectable, a long-acting implantable, and local options. Of these, long-acting injectable and local options are furthest along in development, so we'll discuss those today. On-demand PrEP is an alternative dosing strategy that has been proposed. Instead of taking PrEP daily, which is currently recommended by the guidelines, PrEP is administered around sexual encounters. The proposed strategy is that patients will take 2 tablets 2 to 24 hours before sex, and then they will take another tablet 24 to 48 hours after the first dose. Patients would then continue daily dosing if sexual activity continues until 48 hours after the last sexual encounter. There is also guidance on what to do if there is greater than or less than 1 week break since the last dose and anticipated intercourse. For example, here we see the typical daily administration of PrEP. And here is a proposed schema for on-demand PrEP. So let's say a patient had planned to have intercourse on Wednesday. They would take a tablet 2 to 24 hours before the event and then a tablet after the event. Then they would take another tablet on Thursday and Friday. This scheme assumes no additional sexual activity after that first initial event, but remember, if sexual encounters were to continue, the patient would continue taking PrEP for 48 hours after the last sexual encounter. On-demand PrEP has actually been studied in the iBrigade trial published in 2015. It was a randomized controlled trial in the MSM population in which patients were randomized to receive on-demand Truvada or placebo. The incidence of HIV infection was lower in the PrEP group. While the results sound great, the major limitation was that the high-frequency sex in the study led to frequent Truvada administration, which caused concern for whether you can truly consider on-demand dosing. The median number of tablets per month was 15, and 86% of the patients had TDF concentrations consistent with having taken the medication during the previous week. Overall, this study did leave some unanswered questions, including what is the optimal time to optimal concentrations in rectal and vaginal tissues, and if 2 to 24 hours before sex was enough. Secondly, would this be efficacious in heterosexual men, heterosexual women, and persons with injection drug use? And lastly, would adherence to the complex on-demand regimen be enough outside the study for this regimen to be efficacious? So the bottom line is that there still are a lot of unanswered questions surrounding on-demand PrEP. On-demand PrEP is currently not recommended by the CDC or the FDA, so I would caution anyone to encourage or promote on-demand dosing until we have more literature. The Ivory study does perhaps suggest that PrEP may still reduce risk in MSM without perfect daily adherence. However, adherence should still be highly encouraged. Next is an alternative PrEP option currently in development. This is the long-acting injectable integrase inhibitor, Cabotegravir LA. It is currently being studied with administration scheduled with 2 doses 4 weeks apart, followed by every 8 weeks thereafter. As you can see in the table above, there have been several clinical trials with 2 phase 2 trials that have been completed. These compared Cabotegravir to placebo in men and women in various countries. The phase 3 trials are currently still recruiting and look at Cabotegravir versus Truvada in MSM, transgender women, and heterosexual women. The results of the phase 3 studies are expected to be completed in 2021, so something to keep an eye out as it can be instrumental in overcoming the adherence barrier we mentioned earlier. Lastly, the Dapivirine Ring is a local option that is one of the furthest along in development. It is a long-acting intravaginal polymer-based ring. Each ring contains 25 milligrams of Dapivirine and would need to be replaced each month, very similar to the NuvaRing contraceptive method. There are 4 phase 3 trials that have been completed, which are the Ring, Dream, Aspire, and Hope studies. And these studies were conducted in Africa in 18 to 40-year-old females. And the results of this study have not been fully published, but it has been reported that it reduced the HIV transmission by around 30% and was well tolerated overall. The Dapivirine Ring is currently under review by the European Medicines Agency, and regulatory submissions are planned to the FDA. Pharmacists can play a huge role in identifying and managing patients that are at risk and eligible for PrEP. In addition to identifying patients at risk, we are poised to combat many of the barriers that limit PrEP use, as we are considered one of the most accessible healthcare providers. In addition, providers may only see patients every 3 months, while pharmacists may see these patients monthly for their refills. In the community setting, pharmacists are able to promote adherence and safe behaviors when patients come to pick up PrEP. As a community resource, we can direct these patients to various services using some of the tools previously mentioned within this presentation, such as the PrEP Locator or locator.aids.gov website. And we additionally can assist in debunking misconceptions about HIV PrEP. Probably one of the most exciting advances is the emergence of pharmacy-based PrEP clinics, which seems like a perfect fit given the role of the community pharmacy. A study out of a community pharmacy-based PrEP clinic in Washington cited excellent initiation rates and low overall dropout rates and low loss to follow-up rates as well. North Carolina is well suited for HIV PrEP clinics with legislation surrounding clinical pharmacy practitioners. To summarize, PrEP does have the substantial ability to reduce morbidity and prevent HIV-related infections for many of those who are at high risk. Some key components are providing appropriate monitoring, patient counseling, and lowering barriers for PrEP. While there has been some advances in PrEP with varying dosing strategies and the approval of Descovy, there are many additional drugs in the pipeline to help increase adherence to therapy and help combat the HIV epidemic. In closing, we have enjoyed providing this webinar to the North Carolina Association of Pharmacists. We hope you have found the content to be informative. To receive continuing education, please follow the instructions provided for this webinar on the NCAP website. Thank you for your participation.